So the answer is no. So 2 studies show no benefit of steroids in Bell's palsy caused by Lyme disease. Now the difficult thing for us, so if someone comes in and they have Bell's palsy and have any of the symptoms, I don't know if it's Lyme disease or not. I would send a Lyme disease test and we'll probably even start treatment, certainly in a kid. Any kid who comes in with a Bell's palsy, that is Lyme disease in this area until proven otherwise. So we would all, that's considered standard of care to start antibiotics in those patients. But adults, you send a Lyme disease test, and you consider the risk of tick exposure. I mean, if you think it's high risk, you probably start them empirically, but not. You start them on steroids. You give them medicine for their eyes so they don't get a corneal abrasion because their eyes open, and then you go from there. So if someone turned out positive for Lyme, you could call them and tell them to stop the steroids because they're not helping. Okay, chronic Lyme disease, is that a real thing? So the better terms are post-Lyme disease syndrome or post-treatment Lyme disease syndrome. I saw both when I was doing the research. So 5 to 15% of the patient, they get this post-Lyme disease syndrome, and you can see the symptoms: headache, fatigue, arthralgia, maybe some cognitive issues, and this is weeks to months after appropriate treatment. The IDSA and the American Academy of Neurology say, based on the evidence, that this is not due to persistent infection. So see, there's this minority group, some doctors who feel like there's a chronic infection going on when really it's in all likelihood, according to the data, it's this post-treatment Lyme disease syndrome where you're just having residual symptoms but you're not still infected. And they've actually done studies that show no benefit from repeating the antibiotic course. So there are some times when people are non-compliant with antibiotic regimens, and if they didn't complete it, then maybe you would want to repeat the course. Or late disease and like Lyme arthritis, there are some, that's a little bit different animals. Sometimes, if they feel like it hasn't been cleared, they might go to IV therapy, but in general, like this 1 year of ceftriaxone, 2 years of antibiotics, whatever that some people come on in with, that's not indicated, and it doesn't have a benefit. Okay, so pregnant woman contracts Lyme disease. Is the baby at risk? All right, so this is, I thought was kind of interesting. So syphilis is a spirochete, and there's this awful congenital syphilis syndrome. I actually was looking this up a little bit, and if you ever want to stay up at night, just look at some of the pictures. It's like the most disturbing thing looking at congenital syphilis. It's actually very, very sad. And thankfully there's not a lot of that. But that's a spirochete, so there was all this concern, Lyme disease is caused by a spirochete. Is there a congenital syndrome associated with that? So there's really no evidence of that, although what I would say is there were early case reports and some very small studies that suggested maybe there was a risk in association with birth defects. But the more recent data has shown that there's really no link. They weren't able to establish a link. So you're pregnant, you're appropriately treated for Lyme disease. It doesn't look like it's going to hurt the baby. There's no evidence to really support that. Okay, is there a vaccine for Lyme disease? So there was a vaccine for Lyme disease, and this is kind of interesting. Hey, so the vaccine for Lyme disease was licensed in 1998, but it was ultimately pulled off the market, and it got this conditional approval. So it wasn't approved to be a vaccine that you get at a certain age or what have you. It was only in Lyme endemic areas, and if you're at risk, and yada yada. And then it wasn't. It didn't have this legal protection that other vaccines had, because it wasn't a vaccine that was recommended for everybody. So the lawyers just pounced on this thing, and there was no real data to say that this was causing Lyme, an arthritis, given the vaccine caused an arthritis. But there were a couple of people, I guess, who had arthritis who got the vaccine and blamed it on that. Even though there was no data to support it, the company was like, hell no, we're done, we're just cutting our losses and pulling it off the market. So it's unfortunate because it was a decent vaccine. It had some pretty good efficacy. I think they still use it actually in dogs and stuff. There is I think vaccines that they use in animals. So if I have Lyme disease, could I also have other tick-borne diseases? So I answered that before. The answer is yes. So the BZN anaplasmosis are carried on the Ixodes tick. So you can get the same thing. You can get other infections at the same time. Co-infections, that's the range, about 4 to to 28%. So Babesia, we'll go to Babesia now. Babesia is considered like a malaria-like illness, although there are times when it's asymptomatic. People get Babesia and they never know they have it, and they clear it, or there may be some persistent parasitemia, but it doesn't cause them any problems. Other times it's like a very mild syndrome. It can be, very, minimal symptoms, and then other times, we actually admit people to the hospital with severe disease, and they can get, multi-organ issues, and even you can die from babesiosis with severe disease. So those are the symptoms. You can see 91% of the time there's some kind of malaise, fatigue, or general weakness when people are actually getting sick. Shaking chills, 77%, fever, 91%, and you can see just all these general symptoms that are like all these tick-borne and mosquito-borne diseases you'll see as we go through. It's really difficult to differentiate just based on symptoms because so many of the symptoms are generalized. So I had a patient with actually Cynthia Ferran, who's one of my nurse practitioners who's no longer here. So we evaluated the patient together. And this patient came in with abdominal pain, and examined, and I forget why the patient was tender, but we were like, it could be an acute abdomen, so we got a CAT scan, ordered a whole bunch of labs. So I was off doing my thing. So Cynthia then looks at the labs, and what she sees is some of this stuff. She sees that the patient's anemic and leukopenic and thrombocytopenic, and she sees increased ALT and AST, and I forget what else she saw, but she's like, wow. I wonder if this patient has one of the tick-borne diseases, maybe babesiosis. So she sends off a smear, and sure enough, it turned positive for babesiosis, and that's what the patient had. And as soon as we get the result, then the patient spikes a fever, and so I just thought that was a great pickup on that part. There was a case where really, you don't have to have all these things. You really can have very little or just one of them. And remember, some of them are asymptomatic, but this particular patient had abdominal pain. So. Really interesting case. So if you're immunocompromised, no spleen or extreme of age, then you're very vulnerable to babesiosis. Severe, you can get DIC, really ICU kind of stuff right there. And the biggest thing to remember with babesiosis is doxycycline is not effective against it. So there's a different regimen of antibiotics that they use for that. So atovaquone and azithromycin. If people are going home, that's typically what we use. If they're more sick, then we tend to use clindamycin and quinine. You can use, if people are really, really sick, you can do exchange transfusion to try to get the infected red cells with parasites out of the blood. And otherwise, it's just like ICU supportive care for these patients. Okay, so this one I was really confused about for a while. All right, so this is anaplasmosis. It used to be called human granulocytic ehrlichiosis. All right, so they used to lump this in with just ehrlichiosis, and then they realized that it's carried by a different vector. So at least ehrlichiosis is a different vector. We'll get to that in a minute. This is carried on the Ixodes tick along with Lyme disease. Fever, shaking chills, severe headache, malaise, all these like generalized symptoms that you're seeing in all these cases. Again, with the anemia, thrombocytopenia, leukopenia, when we see those things and it's the season, we're just thinking, wow, we think some sort of tick-borne disease, but we don't necessarily know which one it is. I mean, the bullseye and the erythema migrans helps us steer towards Lyme. If someone really is getting anemic and they're having almost like a malaria type of cyclical fever and shaking chills, and it kind of waxes and wanes like that, then we're thinking babesiosis. You just don't know with like this. This is going to be generally just a non-specific disease that kind of raises your suspicion for tick-borne illness. What you see again, it was used to be called human granulocytic ehrlichiosis. So where you see the morulae and the granulocytes in the peripheral blood smear, and the doxycycline covers it. So you look at your doxycycline, you're covering Lyme, anaplasmosis, and then ehrlichiosis, which we'll get to here. So is ehrlichiosis still a thing? So I was like, wait a second, if anaplasmosis was ehrlichiosis, and now it's anaplasmosis, is there still ehrlichiosis? So very confusing. So there is ehrlichiosis, and that's what causes it. It's Ehrlichia staphylos and Ehrlichia ehryngi. causative bacteria. Oops. And that's on the Lone Star tick. Okay, so different tick than the Ixodes. But very similar symptoms as anaplasmosis, and doxycycline also covers it. So it's not critical that you differentiate between the two. Again, the main thing is that you see the symptoms, you have a high suspicion that based on exposure in an endemic area that they may have had a tick bite, then you can start the doxycycline, and you know, it's a 14-day course. You'll cover everything from Lyme to ehrlichiosis and anaplasmosis. Okay, so if you needed a better reason, besides, you know, those three things, Rocky Mountain spotted fever is actually much less common here, but it can be very deadly, and if you miss it, it's a real problem. So again, with the, you know, non-specific kind of symptoms, although you can get focal neurological deficits, rash appears 2 to 5 days after onset of fever, but sometimes when the rash appears, people are really, really sick, and it's already could be too late at that point to treat. The rash starts on the wrists, it goes to the forearms, and ultimately can end up on the palms and the soles. And again, it can be a late finding. Thrombocytopenia, elevated transaminases, hyponatremia, and this one can be fatal. So again, there's all these reasons to just think about, like, when you get these patients, to just empirically start doxycycline on them and not rely on the testing, because the testing isn't that great for any of these things. You know, all these smears that we do smears for Ehrlichia, smears for babesiosis. I mean, Rafali told me it's like fishing. You know, you throw your fish rod in the water, and you know, you pull it out, and just because you don't get a fish doesn't mean there's not fish in the ocean, right? Mm-hmm. So it's the same thing with testing the smears for these parasites. Is that you're not always going to pick it up. You may have to do multiple smears before you pick it up. So empiric treatment is usually good. And babesiosis, usually you get that cyclical type thing. And they're starting to get more anemic, and that really raises your suspicion. So that, you know, even if you didn't see it in the smear, you may start empiric treatment with that. We had a couple of cases with Debbie Spice Handler where we started empiric treatment because we thought the patient probably had babesia. Okay, so mosquito-borne illness. So, Kristen knew she wasn't getting away with getting her head on a bug. Okay, so this is this is she was just camping, so she's very anxious.
I am. I have every single symptom that you talked about from camping.
Okay. So this is from the CDC as well. So this just gives you an idea how widespread malaria is. You know, if you see the red, malaria transmission is widespread. And then the yellow, some parts, and then green, really not, there's no transmission. So if you look at all of, like, North America, Central America, you see some, and certainly South America, but really all of North America, there's really no transmission of malaria. With global warming, that may change at some point. But, travel history. So, you know, we're not an endemic area, so it's travel history that you got to worry about. This is staggering, though, when you think about the scope of this. 219 million cases of malaria occurred in 2017. 435,000 died, and mostly children in the African region. So this is why Bill Gates is, like, basically dedicating his fortune to try to address malaria, among other things. But, like, him and Melinda Gates, you know, all credit to them, have really invested a lot. They've been working on the malaria vaccine. Which is showing some promise, but it's not, you know, it doesn't seem like it really has great efficacy, but it seems like there's some promise there. For us, I mean, it's 1,700 cases a year, and basically these are all travel patients. So anybody comes to the ER, it's fever travel. You know, you got a fever, they're asking everybody about travel history, and that once you get a travel history with a fever, then you know, you're worried. In this day and age, you're also worried about measles and stuff like that, but certainly malaria if you're in the right place. Yeah. We'll get a few a year, you know, and you know, sporadically here or there. I've had a number in my other hospitals I've been at. Certainly in training, I've had them, you know, and it's almost invariably it's in someone who traveled. So generally fever, chills, sweats, headaches, muscle pain, and then severe findings, you can get coma and focal neurological signs, respiratory distress, failure, that sort of thing. So you do the blood smears. The other tests for malaria, they just aren't really that helpful in like the early stage. If you can get an identification of a particular type of organism on the smear, then you're in good shape, because then you know how to treat it. They don't want you to empirically treat because it makes a difference in terms of what the infecting species is. Plasmodium falciparum is the worst. People die at a higher rate for that. It's a more severe disease. Those other three aren't as severe. There's also another one that actually is crossing over from one of the primates, I think in Africa, to humans, and that one is just as bad as falciparum. But I didn't put it up there because it doesn't seem like it's really, I don't think we really have to worry about that around here. So your treatment is, what infecting species, what's the clinical status of the patient, and is there resistance in some of these things. So falciparum is not only the worst, but it does have resistance to some of the agents used to treat it. So you have uncomplicated malaria, you can go out on oral meds if you're not that sick. If it's complicated, then generally we'll use parenteral therapy.